Hello everyone, my name is Justin Kennedy, and today we're going to discuss the following questions. How do we detect traumatic brain injuries? Do we have objective tools? What kinds of gaps do we have? And what are we developing to address them? While this is a pathology we all have an intuitive understanding of, detection and classification of these pathologies has proven to be challenging for various reasons that we will explore. We do have tools we have classically used for this task, some of which are better at detecting particular forms of pathologies than others, but our toolbox remains incomplete. We also have a number of exciting new possibilities for the future, but more work needs to be done to confirm the clinical utility of these options. The two images you see are samples from radiopedia.org. Which of these looks abnormal to you? Which of these two images do you believe has suffered a traumatic brain injury? The CT scan on the left shows the classic star of death, the hyperdensity indicating blood in the subarachnoid space. Indeed, trauma is one of the most common causes of subarachnoid hemorrhage. The T2 MRI on the right side of the screen appears normal. However, despite higher resolution, this normal appearing image may also have a traumatic brain injury. Imaging by itself, at least with our current technology, is insufficient to rule out many manifestations of TBI. When thinking about how to detect brain injuries, it is important to consider the mechanism of injury we intend to detect. And again, Lee in 2019 summarized an excellent framework of discussing these injuries. First, the difference between closed head, penetrating, and blast injuries. The brain remains enclosed by the skull in closed head injuries, and the injury is caused by whatever force is transmitted. It is likely in the form one would consider for most head injuries. A classic example of a penetrating injury is a gunshot wound. We typically think of blast injuries with respect to our military population. Shockwaves propagating through the brain parenchyma can cause unique forms of injury. Modeling of TBI changes significantly depending on these three large categories. Next, we have primary injury. Primary injury can be split into focal and diffuse. The impact itself, the coup, and the secondary impact of the other side of the brain as it accelerates into the skull, the contra-coup, create localized contusions and injury. However, diffusely, axons can be injured from sudden mechanical distension. This diffuse axonal injury is a key cause of morbidity but remains difficult to accurately diagnose and treat. Secondary injury describe a wide range of sequelae that may occur following injury, including excitotoxicity, mitochondrial dysfunction, oxidative stress, lipid peroxidation, neuroinflammation, axon degeneration, and apoptotic cell death. Each of these forms of injury may cause unique injury patterns and forms of damage. So we've talked a bit about what we may see on imaging or at the physiologic level, but what do we see when we talk to and examine the patient? The following list is a sample of some of what we may see from the National Institute of Neurological Disorders and Stroke. Headaches are a fairly unsurprising symptom. Nausea and vomiting may result from increased intracranial pressure if, for example, there's a bleed or increased poor CSF drainage leading to increased intracranial pressure. Depending on the location of injury, various neurological deficits could manifest, including weakness, sensory changes, visual changes, aphasia, and etc. Key symptoms of concussion include difficulty with concentration and emotional dysregulation, both manifestations of cognitive dysfunction. Abnormal neuronal activity following injury may lead to seizures, both immediately following the injury and for potentially decades afterwards. What is the key underlying principle tying together all these facets of traumatic brain injury? Heterogeneity. One can easily see why detection and classification of these injuries has remained quite challenging. Let's talk a bit more in detail about the modes of detection that are often used today. We've touched a little bit about them already briefly, but let's kind of summarize the tools that we have covered. First, we have neuroimaging. Computerized tomography, or CT, is an excellent modality for detecting large structural lesions, bleeds, or skull fractures, but exposes patients to radiation and does not have the resolution to detect many forms of injury. MRI is more sensitive, but slower, and may not be available in lower resource areas. Susceptibility-weighted imaging is a type of MRI sequence that can detect microhemorrhages, a proxy for diffuse axonal injury, but this method is far from precise and lacks prognostic ability. The neuro exam is the best way to spot any focal deficits that may result from TBI, but many, especially with mild TBI, may not have any focal deficits. In addition, other traumatic injuries may limit this exam. The Glasgow Coma score is a 15-point scale based on motor responses, verbal responses, and opening eyes used for various forms of brain injury, including traumatic brain injury. Ganarelli et al. In 1994 did demonstrate a relationship between mortality and a worse score, but many injured patients may have a perfect score and remain impaired. A few injuries may cause increased intracranial pressure and this warrant monitoring, but once again, while this is a life-threatening complication, this represents a limited pool of those with traumatic brain injuries, thus not necessarily helpful for the broader group. So, I'm sure you've seen the name of this talk. Why biomarkers? Hassan et al. Outlines an excellent collection of advantages of biomarkers. They offer the potential for easy quantitative classification of severe injuries. They have the potential to act as screening for, or in some cases even replace, CT and MRI imaging. Right? MRI is quite expensive, and CT scans do expose our patients, as aforementioned, to a lot of radiation. In particular, we can think about our pediatric population as people we'd want to shield from this. Several biomarkers have shown promise for prognosis. The diagnosis of diffuse axonal injury remains challenging for many conventional forms of imaging, and that's something some biomarkers have shown promise with. In addition, in patients with confounding neurological exams due to other injuries, these biomarkers may help us with finding brain injuries amidst other distractions. So, what are we looking for when discussing a promising candidate? These characteristics are important for any diagnostic testing or screening. First, sensitivity and specificity. I want to be able to trust the result. Meaning that A, when the concentration is low, there actually is not an injury, and B, when the concentration is high, there actually is an injury. It sounds simple, but getting the ratio between these two correct is a very important aspect of an effective screening test or diagnostic test. Next, we want an early change in the marker after injury so that we can quickly see evidence of injury. A marker that changes over time can be something that we use to follow how the injury progresses. Does the biomarker drop after resolution so that if this happens again, we can still detect it? Finally, how do we actually get a measure of how much of this marker there is? Saliva is relatively easy, for example, but serum is a bit more intrusive. CSF will likely require a lumbar puncture, not a procedure we would like to do routinely, as this increases the risk of complications. So what are some candidates that we're considering for these biomarkers? Hussain et al. Has outlined a really good list of some of the promising ones that received a lot of study in recent years. This is a far from comprehensive list, and it's entirely feasible that a marker entirely aside from this list is what will become mainstream. So first, we'll start with S100B. This is an intracellular calcium binding protein. It plays roles in cell motility, metabolism, and proliferation. This does vary with age, meaning that we'll have to actually measure the concentration of this hormone across different ages and account for that accordingly when using it in clinical decision making. This biomarker is also elevated in people of color during extraneous activity and in extracranial injuries, all things that will once again have to be accounted for in clinical decision making. It's got good sensitivity, but poor specificity. So perhaps one could think of the best utility of this as a screening tool to see if further imaging or testing needs to be done. It does have poor predictive value. Yeah, but it does clear quickly, which is, like I said, an important advantage for using it in potential repeated trauma. Next, we have GFAP, glial fibrillary acidic protein. This is a cytoskeletal monomeric filament protein. It's got great sensitivity and specificity, and it does correlate well with some of the tools we already have, GCS or Glasgow Coma Scale and MRI. It's a great prognosticator as well. Next, we have ubiquitin C-terminal hydrolase L1, or UCHL1. This ubiquitinates damaged proteins for recycling, and actually works really well in combination with GFAP, or glial fibrillary acidic protein. I think this is actually a really important point, that when going through these markers, we don't need to consider them necessarily in isolation, but perhaps the best perspective would be to use them in combination with others. There was evidence that showed some effectiveness that distinguished between no recovery and some level of recovery, but when distinguishing that what level of recovery within the recovery group, this was much poorer. And this does work best at a GCS score of 3 to 12. However, a lot of mild traumatic brain injuries have a GCS score of 13 to 15, meaning this may not be effective for a large portion of the kind of brain injuries we'll get, but more effective for the more serious injuries. Tau. We've all heard of tau in relation to neurodegenerative diseases, and it has received extensive study in that area as well. This is a microtubule-associated protein. This also increases with age, just like S100B, and thus is something we need to account for when measuring normal levels of it. Tau is well correlated with repeated TBI and concussion, given the potential outcomes that can be associated with this. That's an important thing to note. Next, we have neurofilament light, or NFL. This has been investigated heavily in axonal injury and correlates well with outcome. There's that prognosticability I mentioned earlier. This peaks days to weeks later as well. It's a little bit more of a delayed following, something that needs to be accounted for as well. So this is a great summary table created by Hussain et al. Just to kind of point out some key points on this table, it's important to note the other sources that all of these markers come from, because this is a source of a lot of the error that might be associated with these tests. For example, I mentioned earlier that S100B is increased in people of color, and if you look at this table of other sources, we can see that this is actually produced by melanocytes as well. The half-life of these is also important, as well as the peak. It's important to know about, consider the kinetics of this, and kind of map this onto the clinical picture and how much time we think has passed since injury to kind of put the number that we're seeing into context. It's important to know that, for example, for NFL, we don't have a great idea of its precise half-life and peak, which is going to make it a little more difficult to use clinically. This is a nice little graph of what we do know about the kinetics over time. Just to point out that most of the biomarkers I mentioned, UCHL1, GFAP, tau, and S100B peak pretty early, while NFL seems to have a continued rise over time. Tau seems to peak at least two separate peaks as well. And once again, this is an excellent graph created by Hussain et al. Summarizes some of our findings for the kinetics of these biomarkers. And so, what are the takeaway points from where we are in this field and where we're going? First, traumatic brain injury is a heterogeneous pathology that is very difficult to detect sometimes. Biomarkers have the potential to help improve that detection and prognostication for traumatic brain injury. Factors to weigh in picking a marker, or really any sort of screening or diagnostic test, are sensitivity, specificity, where we're finding that factor, any confounding sources for that factor, and how that factor changes over time. And among the biomarkers, GFAP seems to be performing the best, but we probably need more work to really bring it to the clinic or see if there's any potential better options. All right, thank you. I hope you have a wonderful day.